for being here. We were talking a little bit before the presentation. We're talking about the diehards who are really going to come to the last part of the conference. So we appreciate you being here. I'm Adriana Foster. I'm a professor of psychiatry and behavioral health at Herbert Wertheim College of Medicine. And I have the pleasure to introduce my team as well as speakers today. And I'll pick up a little bit at the end of the presentation. But I want to introduce Simran Sandhu, Dr. Sandhu, who is our research fellow, Matison Alderman, who is a second-year medical student, and Laura Ayala, who is a pre-med and English major student, and she wants to be a medical student. So we have kind of all generations here, and with that, no further ado, I'm going to ask Dr. Sandhu to pick it up from here.
Hello, everybody. Thank you for coming. So today we're going to be, let me just make sure this is working. Today we're taking the teacher out of the feedback using artificial intelligence to train communication skills. So, first of all, I'd like to talk to her about our disclosures. Dr. Foster is supported by grants from HRSA and IMH. Myself, I'm supported by the Evers Foundation, and these two lovely ladies are not. They don't have any disclosures. Our objectives today, after today, we should be able to describe what the most recent suicide risk assessment teaching tools are, and we should be able to appraise how artificial intelligence is being used right now in order to teach suicide risk assessment to clinicians. Okay, what do we know about clinicians' behaviors and interactions between patients who are suicidal? The thing is, it's hard for us to get feedback from patients who are suicidal because of several reasons. First of all, it's a very high risk population. The point of care when it's happening, it's very difficult for us to get feedback when we are dealing with the suicidal patients because it's a crisis situation. We can't be doing that at that point of time. So it's very important that clinicians are trained how to do this beforehand so they can be ready to deal with the situation when it comes. So a bit facts about suicide and why this is important. As you see from the WHO and the Centers of Disease Control, it's the 10th highest cause of death in the United States at the moment. In the ages of 10 to 34, it's the second leading cause, and it's the fourth leading cause in ages 35 through 45. So this is a pretty serious problem at the moment, and we need to be able to have clinicians be able to do suicide risk assessment. The rate has been increasing since 1999, especially from 2007. The rate has gone tremendously higher and higher every year for many, many different reasons. And this is very important. Out of people who die of suicide, 38% visit a healthcare provider within a week, 64% within a month, and 95% within a year before they make the suicide attempt. So it's very important for clinicians to be able to spot somebody who is in a suicidal crisis situation, because there's a good chance that that someone who's about to commit suicide has seen a clinician before. So also people with mental health and substance abuse diagnoses who attempt suicide, 25 visit a healthcare professional within a week, 44 within a month, 73% within a year. So it's very important for us to be able to spot out when this is happening. Okay. There is a study in 2016 that showed that staff psychiatrists were the best at predicting suicide amongst all clinicians. Then came junior residents, senior residents, junior residents, and medical students. So as you can see, we haven't trained enough there isn't enough suicide risk assessment training inside of elementary training inside of different med schools, different therapies, we really have to train clinicians before they're rooted inside of a specialty, so that we can get these numbers up, because yeah, it's a huge problem in today's society. So we have to be able to train people. There's many problems that happen when there is a suicidal situation happening. Many clinicians, they end up asking negatively phrased questions, such as, "You're not having any suicidal thoughts, are you?" This causes the patient many times to react negatively, and this would cause a lot of clinicians to miss a great opportunity to be able to save somebody when they are in this kind of situation. Instead of asking, for instance, "Are you having a suicidal thought?" They end up asking something phrasing it in a negative way, which has a big impact. There's also something that has Igor Gayenker's work, Dr. Gayenker from Mount Sinai, Beth Israel. He's done a lot of work that shows that a clinician's negative emotions, it has huge impact on a suicidal patient's outcomes. So we're all human beings. We all have emotions. We all react a certain way when we're confronted with a patient or with different kinds of people. And it turns out that a lot of times a clinician isn't aware that they may be acting in a negative way, or they may be having countertransference, which is their own negative feelings towards the situation that's happening. And this has been shown to have very big, it has an impact on the outcomes. And so we have to find a way in order to be able to understand what we are going through ourselves. And this is a very hard thing to do, It's not like you can ask a patient, "How am I feeling how do you feel like I'm feeling at the moment?" So, it's very important for us to somehow get some kind of feedback that tells us how we are portraying ourselves or towards the patient, because it has an impact on the way that the outcomes of the suicidal patient. So, okay, virtual humans and artificial intelligence. That's really what we're here about, right? So virtual humans, they're avatars. They're avatars that are created. They can take many, in this case, they're 3D avatars. They could take any gender, any race, any age. We can program what the avatar says. We can program how the avatar reacts, and then we use artificial intelligence in order for it to react in a certain way towards the clinician who's interacting with it. So there's many different ways we do this. Our avatars, our virtual humans, they're made by Virtual People Factory. It's Dr. Locke from the University of Florida. He uses Virtual People Factory. And this creates avatars which can have any range of symptoms, can behave in any certain way you want them to. So there's a lot of advantages to using this. And for instance, in suicide risk assessment, as you see, there's only upfront costs. If you're using SP simulated patients, you have to pay them again and again and again. It's portable, easy to disseminate, repetitive practice. It allows for repetitive practice. All you really need is you need the internet. You can use your iPhone. You can use your tablet, computer, anything. So you don't need an actual human being to work with, obviously. It gives immediate feedback on multiple variables. So, for instance, it tracks multiple aspects of the interaction. So voice, the way you're talking, the way your face. We're using facial recognition. NOLDIS is the name. And NOLDIS it can tell if somebody is having an anxious, nervous, positive or negative facial expressions to how they're reacting to a patient, for instance. So obviously there's no risk to any patients or SPs. When SPs do, there is a harm to SP. There can possibly be a harm to SPs who are trying to pretend like they are having a suicidal crisis at the moment. You know, suicidal contagion, I believe is the word. It can affect people negatively. So obviously there's no harm in that with using a virtual human. And you get a full transcript of the interactions, so you know exactly what happened. You could look at it afterwards. You could see how you reacted, if you said the right or wrong things, for instance. And the data does show that using a virtual human can be used to teach empathy. And there's many ways you do that, mainly through the feedback and giving the virtual human giving suggestions back on to how to react better, or maybe say something in a different way. And if you're not having empathy, if you're not responding to the virtual patient with empathy, it'll tell you this. So now I would like to introduce, what happened here? Did it shut down? No, this is no. It looks like PowerPoint just shut off. No, it's not. Okay. There was a problem with Microsoft PowerPoint and it was closed. Great. Okay, let's try to open that again. Do you know? Oh, we got to get it through here, right? Oh, okay. Great. This one? No. You want to do it? I guess we're having a technical issue at the technical conference. So, there we go. Thank you, Matison. Okay, so this is Bernie. This is Bernie Cohen. Bernie Cohen is a 53-year-old homosexual male. He suffered a catastrophic loss of his partner, died of cancer, and he's come in with a lot of suicidal ideation. So the way that you would react or interact with Bernie is you could either type it in, you could push the microphone and ask Bernie questions, and Bernie understands what you're saying. Well, understands what you're saying. He reacts in using artificial intelligence, and he reacts to what you're saying. So he gives, for instance, empathic opportunities. He gives you, you can elicit discoveries, for instance. You can do an HPI, personal history, everything. So yes, and then through Bernie, there's many other things you can do. You know, using the virtual human is attached to the artificial intelligence, and the artificial intelligence also, it could do, like I said, it can record your facial expressions as you interact with them. Your voice, the way your voice goes. Next, we have Cynthia Young, and Cynthia Young is a college student. She's also experienced a loss, and her grades have been slipping. She isn't in so much of a crisis situation as Bernie, but yes, it's just another avatar, and she gives you an opportunity to learn how to speak to somebody who is having this kind of crisis situation. I can give you guys a little sample of what it's like to work with her. Okay, here's Cynthia. And So you hit the microphone, and then you ask a question for, how are you today, Cynthia?
I feel down all the time.
Hit the microphone again. You can ask, did something happen recently?
Well, my cousin died.
Okay, and how do you feel?
I feel hopeless. I wish this would all end.
I'm so sorry to hear that, Cynthia.
Okay, thank you.
So, as you could see over there, I was not all that empathetic in that interaction, and so there would be, you elicit these discoveries. It gives you we use something called the ECCS, which later Laura is going to get into, and that gives you, it's a coding on how empathetic your responses were. So for instance, that would only be a 3 out of 6. And then it gives you suggestions on how to maybe give a better, more empathetic response, for instance. So, okay, is this yours? Yeah, okay.
Good afternoon. Thank you guys all for being such good listeners. So I want to talk more about what the suicide risk assessment is. Everyone probably isn't too familiar with that. By definition, it's an assessment that clinicians will use to determine the patient's risk for suicide. As you saw from the previous graph, that clinicians were able to better predict suicide risk as they had more experience, I think that really emphasizes the fact that it's not just a simple formative assessment. It's a gut feeling that the clinician has. So what we're trying to do is, how can we teach students, starting at the medical student level, to qualify that gut feeling? These virtual humans help us do that. So we can't teach that at the clinical point of care. The risk is way too high. If the student isn't able to accurately determine the suicide risk assessment, a patient will die. Our current teaching tools include standardized patients, which we alluded to earlier. Those are expensive. Those require a lot of training. And there is a possible risk of the standardized patient with suicide ideation, having to portray that role. It does have an impact. There has been studies that show that. We also use role-playing. Asking students to pretend to be suicidal probably isn't the best idea either. Videos, lectures, case studies, panel discussions, questionnaires. So in a survey conducted with pediatric residents, they expressed that they did not feel prepared once they began their program, and that they actually did not like many of these. They preferred the case-based discussion where they were able to get one-on-one interaction with clinicians and those of higher level. Those, again, require time and lots of coordination and are difficult. One thing that we try to highlight with our intervention is feedback. So right now, the current feedback is from standardized patients. Again, these are essentially just actors. They don't have the most experience with suicide prevention. Feedback also comes from lecturers, panel members, and questionnaire results. So typically, they're not specific to the clinician's performance. So what we can offer with our virtual humans. At the end of your encounter with the virtual patient, you get a descriptive suicide risk assessment. This is based on assessment risk factors that the APA has provided, and again, suicide crisis risk factors that have been identified in recent studies as well. You also, at the end of your interaction, you complete an emotional response. It's called the Therapist Response Questionnaire Suicide Form. I'll show you that in the next slide, but that is another form of feedback that you get after interacting with this virtual human. Laura will also talk about the ECCS, and again, additional feedback that you would not get in a typical interaction that we're currently offering. This is the Therapist Response Questionnaire form. So after the clinician interacts with the patient, they will answer these simple questions. She, meaning the patient, made me feel good about myself. I liked him or her very much. I felt like my hands were tied and I was put in an impossible bind. Very simple questions, but really digging deep into how you felt when you interacted with that patient. So you're going to rank it based on a scale of 0 to 4. This is what you will get back after. So you're given 3 scores. You're given a hopelessness score, a detachment score, and a distress score. And then you're also given a global negative emotional response score. We provide you with the the ranges, so you can see where you fell based on your score. Here's a little bit of a better summary. So why is this important? Engaging with acutely suicidal patients can be traumatic for the clinician themselves. You often change your facial expressions, you change your body language. This may have a negative impact on the patient. These things happen subconsciously, you're not aware of it. So by interacting with this virtual human, it brings these subconscious movements to light. We are encouraging the clinicians to try to be aware of their emotions. And of course, self-awareness of these emotions can prevent the negative transference. And now I'm going to pass it on to Laura to talk a little bit more about the empathic communication and the coding system.
Thank you. I love technology, but sometimes I like to keep it old school with the flashcards. All right, so like we said, empathy plays a major role in therapeutic alliance. So the higher levels of empathy within the clinician, the better outcome for the patient. And so the empathetic communication coding system, we use a rating of 0 to 6. 0 meaning denial of patient's perspective, and 6, a shared feeling or experience with that patient. So the empathetic communication feedback with ECCS is very important because this coding system is essential with this teaching style because it helps the student understand why they got a certain rating. And with this slide, you see an example of what the student may reply when the virtual patient gives an empathetic opportunity. When Bernie says, "It feels like a piece of my soul was ripped out. All that is left is a bleeding wound." And the student responds, "I once lost someone very special to me. I understand the pain that you are." That would be a shared feeling. So that would be a 6. So these are the examples of the different levels